can see you, and we are all ready to see how you do EUS. Ready? Yes, I can hear you loud and clear, and we can see you. So this is a rectal EUS. I was told. Go ahead, tell us what about Sadaf. आप बता दो.
This is 53 years old female patient who presented to us with history of on and off PR bleed for 1 year. At that time, there was a rectal growth of which biopsy was taken. It was poorly differentiated adenocarcinoma. She had taken neoadjuvant therapy, 6 cycles of chemotherapy. Now she's here for restaging of her cancer. Her CT scan shows thickening of 3 centimeters starting from S3 to S5 level of 5 mm in thickness in anterior wall of rectum.
So it's you can hear me, right? Saad, you can hear me, right?
Yes, we can hear you.
Okay, so it's kind of a restaging. So few issues or few points for the rectal EUS. One thing is I usually use radial, but whatever scope is available. Yeah, a scope to lagwa do. Okay. किधर गए वो?
Wasim?
Okay. So usually I use the radial scope, but I think we are going to do with the linear scope, which is okay. With regard to staging, especially after chemo or radiation, that it's a little more tricky. It's not really 100% correct. Actually, it's accuracy is around 50% or so. The reason is we have explained about the 4 layers before: mucosa, deep mucosa, submucosa, muscularis propria, and then obviously serosa outside. So what happens with the chemo or radiation and chemo, there is a destruction of the tumor that leads to inflammation. That inflammation leads to activation of fibroblast and scarring and everything. So the distinction usually is lost between the layers. So you have to keep that in mind. So it usually ends up overstaging than understaging. So having said that, we at least we can see what the thickness is. Is there really any tumor extending outside the muscularis propria if it still exists? And also you can take a lymph node, take a look at the lymph nodes as well, even though that is not accurate either, because if it's a lymph node, there is a radiation or chemo, same process happens in that. They can look like a little more organized lymph nodes, but that may be just a fibrous lymph node with the fibrosis. And so we're trying to set up a scope. In the meanwhile, we can, if there are any questions besides what I said, I'll answer those. So any questions about this?
I think, Khalid, would you agree that most importantly, that if you have to do FNAs or if you have to do abscess drainage, the linear scope really has a role, and it becomes easier to look at. But to do something that you intend to do is not linear, is not really the best way to look at the mucosa and
yeah, I agree. I would have preferred radial. Major interventions are what we do are besides staging with rectal EUS is, as you mentioned, one is like a FNA, and other thing is pelvic abscess drainage. Pelvic abscess are mostly post-surgical, and the third utility is evaluation of the sphincter, especially the internal sphincter for fecal incontinence. And so these are the 3 major interventions we can do with this rectal EUS. So we'll go ahead and start with this. There's a difference in obviously male and female rectal EUS. When you do the male one, main goal you are looking besides looking at the iliac arteries, you really don't, you can start from there, but main thing is look at the bladder, look at the prostate, look at the seminal vesicles, that help you orient. So in the female, mostly we try to look at, find the, after the vessels, we try to find the bladder itself and put that on the top. So that gives you a landmark that that's the anterior wall. So we will go ahead and start it. Other thing which I do is, if you look at my endoscopic view, I freeze that before I do a rectal EUS, especially in females. Because when you are putting the scope through the anal area into the rectum, I don't want it to be projected on the screen. And that's why you are not going to see any endoscopic view for a little bit, okay? Okay, so now I'm going to go ahead and turn the endoscopic view on. Here, it's a camera is on the side. I'm going to see if I can take a look endoscopically first. So looks like there is some a tumor remnant probably there, or it's just a scar tissue. That's the area where it looks like. I don't see anything else beside that. This is just an anal area right there. You see a little bit stenosis there. So I will move the scope up a little bit to try to go through that stenosis. You see that it's moving through that slowly. And other thing is, always whenever you do a rectal EUS, please make a habit to do an endoscopic view first. I use usually a EGD scope for that purpose, to a flexig first before I go. I use the EUS scope. So here it's okay. We got a good nice view of that. So I'm gonna try to see if I can get a little further in there. And इसको जो है ना थोड़ा सा चलो सही है ठीक है टेबल को इस तरफ कर दे थोड़ा सा मूव okay. So what I'm going to do is let's see if I can go further deeper in there, and if I can, I would like to go a little up further. And this is going to be like because of the linear, so you have to be, one thing is you have to be careful while advancing the scope. We are moving nicely. So I think I'm pretty high up there now. My scope is close to 25 or so. So I think that should be enough. What I'm going to do is I'm going to look for iliac vessels if I could. So what I'm doing is I'm rotating the scope. You see that the iliac vessels nicely? You see that actually it's an aorta right there.
We need the EUS views, please.
Oh, can we put that EUS view?
Now.
Do you have it?
Yeah, we got it now.
Okay, so you see the vessels right there. The main goal is after you see that, you rotate the scope, right and left. So my goal is I'm going to stay in the same position and see if I can go back and take a look at those vessels from one right there. I'm going to go to the other side now and see if I can get back to the vessels, and that would make it 180 degrees. So I don't really see anything major in that area. I'll pull the scope back a little bit and redo the same stuff. My goal is eventually to get to the bladder. And after I find the bladder area, I'll put that if it's a radial, I'll put that on the top, so that would show it to be an anterior wall. Okay. So here, I'm seeing a shadow of the spine right there. Vessels, nothing there, and still coming back. So I'm just moving my scope around and going 180 degrees. So towards the end, what I'm going to do is I'm going to take a really, right now I'm looking for basically the lymph nodes if I see anything, and towards the end, what I'll do is like
so you're just sweeping around clock and
yeah, along it's like a 180 degree sweep around. Now you start seeing the bladder. You see that and at the bottom, that's all fluid or the urine in the bladder. Okay.
Do you normally make sure that the bladder is full before the procedure?
No, not necessary. No, that's not the requirement for rectal EUS. So after I see that, then I'm going to still start this is like this really should be done with the radial. So, but I went around complete 180 degrees from here. Like look at my scope. I don't know if you can see my actual scope or not. Can you see that?
Yes, we can see.
Okay, so look at that. I'm right here. Now I'm rotating my scope. I'm staying in that same area. Look how the scope is going down. So scope going down under, I get back to the same structure. You see that?
Yep.
So it's 180, and that's how you do a really full circle examination with the linear itself. So we still don't see anything. I see the nice walls up here. Like right here, you see all the nice walls there. Muscularis is there. Bladder itself right there, and the rest is just a fat tissue in between. Now the goal is to go at the area where the tumor itself is, which we saw earlier endoscopically. So for these rectal cancer staging, as I mentioned, I think we don't have a radial scope here, right? It's not available right now.
Our scope is actually broken, so
Okay.
that's why we don't have it. Otherwise, we did.
So here, you see that area? I think that must be where the tumor was. I don't see any other.
I think it's a little bit more distal to where because that's kind of a slight stricturing that we saw
Yeah.
just around that area.
So right here is the really stricturing. You see that? Right underneath here. Let me see if I can get through that again. I think this is the area right there. So I will put the EUS probe right on top of that, and
We get EUS, please.
I don't see any.
EUS. अकरम उनसे बोलो EUS नहीं नजर आ रहा. Okay, got it. Thank you.
You got it. Okay. So I'm looking around that area. I really don't see any. What I'll do is I'll make the image bigger, because the main goal is to take a look at the wall layers really. Don't see anything. Don't see anything major. I may not really see anything because I don't see any. There is a little bit thickening there, but it's mostly outside. I don't see anything, any lymph nodes there. Okay, so I'm coming back now. So ideally, either use a probe or radial, as I said. Okay. I will put the probe again on that area. Really don't see any tumor in that. Okay. Yeah, looking at for lymph nodes or any mass in the rectal wall area, there was a little bit thickening in this of the muscularis which you have passed by, but otherwise, no, nothing there either. Okay. So the bladder comes again. And they said it was an anterior wall before, so this would be the anterior right above the bladder. So I can keep pulling the scope back. Don't see anything there either. Okay. Don't, right here maybe. So here, I don't see any tumor there. Do you guys can see the wall layers, right? You see the wall?
Like you said, post-chemo radiation, you expect a little bit of thickening as well as a bit of a change in the way they
In
appear.
the way it looks like, but I don't see a mass, I can tell you that.
Yep.
And I don't see any lymph nodes. I'm rotating my scope all around, looking for any lymph nodes, even though that may not be 100% accurate staging either. So here, I think this may be the area. But again, You see that this may be the area.
Yeah, but that's what I was saying, that
Yeah,
this
so-
particular area that we are seeing.
And it's on the interior wall towards the bladder area. So I think that's the area, but it's not really a cancer.
Yeah.
Yeah, it's a, you
But,
still,
that would go clearly by the fact that she's undergone treatment.
yeah, I don't see really a cancer right there. So it looks, to me it looks fine. Okay. What I'll say is like probably some post chemo changes, a little bit thickening, but no actual mass seen. So here I will come out a little bit and see if I can. It's really hard to appreciate the the sphincter with this, but we'll see if we can. So here, you see that it just came out. I'll go back a little bit. Right there. This is a part of the internal sphincter. You see that? It's a very thick.
Yeah, we can see.
Yeah, so that's a part of the internal sphincter. I'm already out endoscopically, so let's stop that. So really, we did not see anything major on that. Okay. No lymphadenopathy, slight wall thickening at the area of prior tumor, and no tumor noted.
So in rect EUS, when you're using linear scope, like you did, you went up to about 20, 25, you looked
Yeah.
at the vessels,
Looking for vessels.
and then once you found the vessels, you just basically swept one way and the other.
And yeah, so linear mainly is used for FNA
Yeah.
and some therapeutic purpose in the rectum.
But
But
I
it should be done
But
again.
I think to find that lesion or what you want to do an FNA for, or for an abscess, you need to be able to find it.
Yes,
And
exactly.
to find it, you've already seen how how you're supposed to find it.
Yeah, exactly. It's
So
a
you're actually sweeping the.
it's 180 degrees. So you need to find either the vessel or the bladder and look at one time and then go 180 degrees and on the other side, and then you just go back and then you go again. It's like you keep making back and forth movements up to 180 degrees. Slides the wall thickening at the area of prior tumor. No mass noted. No lymphadenopathy noted. Okay.
Khalid, can you just tell us how, what would be different if it was a male patient?
So in the male and especially with the radial, what would you see is first thing you go in, finding the iliac vessels, you come back, you see the bladder. You put the bladder right on the top and you start pulling your scope back in the same axis or same orientation. Next thing you would see is lot of irregular, what may appear like a vasculature or a cystic structures, I should say. And when you put a flow on those, you don't see any flow. Those are the seminal vesicles. You pull it further down, you're going to see a prostate there. And that you clearly see that. It looks like a mass, it looks like a big, huge lymph node. Just remember that you're going to see may possibly see ear in the center of it, which is the urethra, or you may see a calcification in there too as well. And but you mostly you will see a little bit because of the urine, you probably will be easily able to recognize that. And then you keep coming back, then you see external sphincter and internal sphincter and external sphincter. So these are the structures you are looking at. But you can put some water in the rectum and also make your inflate your balloon, so and to approximate the EUS scope to the walls. So that's how you do the examination on it.
Great. Thank you.
I think we're going to go to the other room, right? They are ready?